Okay, good morning. My name's Sean Emery from the Kirby Institute. I welcome all colleagues, both notorious and otherwise. It's my pleasure to introduce the next speaker, Professor David Cooper. David does indeed boast an enviable CV. He is properly recognised for a lifetime contribution that is both substantial and significant, and parenthetically, he assures me he ain't finished yet. The impact, depth and breadth of his body of work is such that he could have legitimately chosen any number of topics to address in this morning's symposium. At a time when scientific discourse regarding HIV has become consumed with a number of probably hyperbolic objectives, we should never forget the extraordinary advances that have actually been realised as a consequence of the development of antiretroviral drugs. Given the enormous contributions made by David to the use of these miraculous molecules, it is my pleasure on your behalf to welcome Professor Cooper, who will address the symposium with a presentation entitled 30 Years of Antiretroviral Therapy. David, thank you.
Thank you, Sean.
Perhaps you should let somebody else stuff it up for you.
Maybe. Oh, it's already on. Oh, sorry, it's already on the thing. Don't worry. I think it's on the screen. Yeah, I didn't realise.
You put me in harm's way again.
Sorry. Okay, I thought I'd use this opportunity to give you a little bit of a historical talk and perhaps say a few things about where we're going of 30 years of antiretroviral therapy. I thought I'd start off by just asking you to all think where you were 30 years ago. Oh gosh. And that's where I was 30 years ago in Boston, Massachusetts, in our backyard in Brookline, doing the mowing. I think it's the last time first and last time I used a lawnmower. And you can see it's electric, and I didn't like the opportunity with the thing around my neck. But that's where it all started. So I want to talk about 6 different things today listed here. Firstly, primary infection. Does this work? Yeah, okay. So we first described in the Lancet acute retroviral infection in 1985, indeed with some colleagues that are here today. We described the clinical features, particularly the rash associated with primary HIV infection. It's a pity I can't even call him David Jones anymore because it's been taken over. You can see his underwear with the familiar pattern. We then analysed the clinical findings in 12 cases in that original Lancet paper. And the clinical findings are the same today. They really haven't changed. And the duration of the illness is an average of about 10 days and has these characteristics of a mononucleosis-like illness, which is sometimes hard to recognise and it's sometimes easy to recognise depending on your location. Together with Alison Imrie in the lab, we got one of the first immunofluorescence tests from Jay Levy in San Francisco. We were able to document seroconversion. We were able to document the antibody response, both IgM, IgG antibodies, and showing, in fact, with the first generation ELISAs how terrible they were in terms of first detection of antibody. Together with Brett Tyndall, we were able to show that the immune response to the infection was very characteristic, and again still hasn't changed to this day. The initial dip in the CD4 cell count, in some cases more extreme than others, and then the return of the CD4 cell count to normal, but also the feature of this massive increase in CD8 cell count, which stays for the duration of the infection, is a very important immune response to HIV. We were involved in actually treating it. We participated in the first trial of AZT monotherapy in primary HIV infection, which was liaised by Brett Tyndall at the time with the Swiss group led by Sabine Kinloch in Geneva, and showed a modest benefit of AZT monotherapy over a short period of time in primary infection. In a clinic cohort, Gilbert Kaufman in the late 90s, early 2000s was able to show that the CD4 restitution in primary infection was ever so much better compared to people treated during chronic infection with the same triple therapy antiretroviral regimens. And again, suggesting for the first time that early treatment was going to keep your CD4 count a lot higher. Then with Kirsten Cole, Sean Emery and Tony Kelleher, we set up the PINT study to compare the viral kinetics using integrase inhibitors, in this case raltegravir, with two nucleosides, particularly looking at the viral reservoir. We were able to show two things. Firstly, that the viral reservoir was much less in primary infection than in chronic infection, and secondly, that when you treated during primary infection, the reservoir went down quite considerably to very, very low levels. Lastly, in primary infection, we participated in a multinational trial coordinated by the MRC with Tony Kelleher as the principal investigator in Australia, called SPARTAC, the first randomised study of combination antiretroviral therapy in primary HIV infection, showing a benefit of treatment of 48 weeks duration in primary infection in terms of time to low CD4 or the initiation of antiretroviral therapy, again suggesting that there is a benefit for starting treatment during primary infection. So what's the future? Primary infection is a very important window into studies of pathogenesis, treatment and cure. Compared with chronic infection, there's clearly less viral burden and more preserved immunity. And better ways must be found of identifying seroconverting patients to take advantage of this very critical window, both in understanding pathogenesis, understanding treatment, and in a public health approach to treatment, particularly as during this period the viral load is very high and accounts for about a third of all transmissions over the lifelong history of a person with HIV. Okay, so moving on to antiretroviral drug development. Initially we had AZT, and we had AZT monotherapy. And we studied it very early on. We were one of the countries that were fortunate enough to get our hands on AZT. I remember David Pennington, who's in the audience here, telling Richard Doherty and myself that we had to attend a meeting in Paris where this wonder drug was going to be discussed. And so Richard Doherty and I duly packed ourselves up on the plane, and that was in fact when I first met Françoise. So it was a really riveting experience to see the first drug come out. Before 1987, the median survival in Australia was 44 weeks. This was analysis of a cohort of people that was done with Cheryl Swanson at the National Centre at the time, and then with AZT monotherapy, that median survival increased to 124 weeks. We looked at the factors associated with this median survival, and again, the same sort of thing that we see today. If you're not anemic, you do better. If your CD4 count is higher, obviously you do better. And the other very important thing that we know now from repeated trials of early initiation of therapy in opportunistic infections in people with HIV who present with opportunistic infections, that the quicker you get on therapy, the better your outcome, as is seen here. If you got on AZT within 12 weeks of diagnosis, that you did much better. Together with Wellcome, who were the manufacturers of AZT at the time, we looked at whether high-dose acyclovir in combination with AZT would do anything, and to our amazing surprise, and very consistently in both AIDS patients and patients with symptomatic disease, the addition of acyclovir, high-dose acyclovir to AZT monotherapy had a survival benefit. And this was disputed by lots of Americans who absolutely didn't believe it, and how could acyclovir possibly do anything like that? And yet the randomised data was very compelling. It wasn't until the late 2000s that some virologists very convincingly showed that acyclovir in fact has anti-HIV activity, and to prove that, it actually develops a mutation, the V75 mutation. The partners in HIV prevention then did a study in Africa of acyclovir in HIV-infected women, and to really look at transmission, primarily of herpes, and whether that was associated with HIV transmission. And what they showed, quite amazingly, was not only, of course, that it had a benefit on HSV2, which you would expect in women, but it also had a 0.25 to 0.3 log reduction in HIV viral load. And so quite clearly our results of those high-dose acyclovir with AZT studies were correct, and at that time a 0.3 log reduction in your viral load in addition to AZT was enough in those very dark days to give you an extra survival benefit. We then looked in more earlier disease at AZT monotherapy in a European-Australian study sponsored by Wellcome, and showed a modest benefit of AZT monotherapy. The MRC and the ANRS continued this study for a lot longer, and showed in fact that early versus deferred AZT therapy had no additional benefit on survival, which was very disappointing. Nevertheless, this was one of the first studies to look at people over 400. I mean, you have to think about this. This is amazing at the time, people being treated over 400. With Tony Kelleher, we were fortunate enough to look at Ritonavir as one of the first protease inhibitors, and Tony was able to show very, very clearly the extraordinary restoration by protease inhibitors of immunity, particularly CD4 responses, both naive and experienced. Together with Glaxo, who had developed 3TC, we looked at, in a large international study, the additional survival benefit of lamivudine in adding to AZT or DDI therapy. And we showed that when you added 3TC, you had a substantially significant improvement in survival in people taking lamivudine. Glaxo were very good at the time, and they partnered with Janssen with an early non-nucleoside called lovaride, and we tried to give a triple therapy, but unfortunately lovaride was a drug with a very, very modest benefit and didn't add to the benefit of lamivudine. So where were we just before 1996? There are 4 drugs, AZT, DDI, D4T and 3TC, and a little bit of DDC. Around the same time as we were doing the CSER study with 3TC, the ACTG worked with Indinavir, one of the other first protease inhibitors from Merck, and showed that when you added Indinavir to AZT and 3TC, again you got a survival benefit, and that of course was announced at the Vancouver meeting with great fanfare and great breakthroughs in terms of the outcomes of people with HIV. At the same time, working with Julia Montana and Joop Lange, together with the Boehringer Ingelheim folks, we were able to show that, that a triple combination, this time with a non-nucleoside nevirapine, instead of the protease inhibitor Indinavir, was also able to produce a remarkable response in terms of getting people below detection, at least 50% in this study, and of course that got better over time with more powerful and potent drugs. DuPont Merck then came up with efavirenz and were able to show that efavirenz in fact was better than Indinavir in this licensing approval study for efavirenz led by Shlomo Stashevsky. So, in fact, the paradigm changed dramatically from the days of AZT monotherapy, where there was a transient benefit in viral load, which then developed resistance and virus went back to baseline. Dual therapy did a little bit better, such as we showed in the CSER study, but the virus still came back with resistance. It wasn't until you gave triple therapy that you were able to have a substantial reduction in viral load and prevent the evolution of resistance, as you can see in this slide from Eric de Klerk. So now, between 1996 and 2003, we came up with 2 non-nucleosides and quite a few protease inhibitors. Unfortunately, many patients during that period of time had what we understood to be serial monotherapy, so that they received drugs after drugs after drugs on top of developing resistance to the first-line inadequately suppressive drugs. And so there was a whole heap of patients who were doing very badly with triple-class resistance to nukes, non-nucleosides and protease inhibitors. And so there was a need for new drugs to take care of that. And indeed, the pharmaceutical industry came up with a marvellous development of many new drugs to take care of these patients. And I've listed the studies, the licensing studies, all of which we participated in, that showed the benefit of addition of, to optimise background therapy of T20, Topranavir, Darunavir, Etravirine, Maraviroc, and finally the integrase inhibitors, Raltegravir. In fact, doubling the overall response rate, such that now anyone who takes their treatment correctly does extremely well. So now, to 2014, we have 5 different classes with quite a few drugs to choose from. And what's the end result? The end result is absolutely extraordinary. So this is data from AHOD run through the Kirby in Matthew Law's group, the Australian HIV Observational Database. This is looking at so this is from Hamish McManus. That was published recently, looking at 10-year survival by age and CD4 count in people who are suppressed. And you can see that anyone who achieves in Australia a CD4 count above 350 and is with suppressed virus has the same life expectancy as the normal population. What of the age match? So what a journey. So what's the future? Sadly, the pipeline's dry. The development of a Me Too drug is very costly when the incremental benefits are really marginal. So a company developing a drug that goes to 92% from 90% viral load below detection, it's not a worthy benefit for their shareholders. And implementation research on how to preserve antiretroviral durability then becomes essential, and we really must not repeat the TB treatment outcomes, which have been really a global disaster. I think one of the ways to go that the pharmaceutical industry is now looking at is long-acting injectable antiretroviral therapies, long-acting monoclonal antibodies, and I think that this is with one injection a month or every 3 months, this might be really worth pursuing very aggressively. So, okay, the next topic is strategy trials. We've participated in a number of these strategy studies together with the MRC and ANRS. We participated in the Initio study, and that looked at 4 drugs versus 3 drugs, and we showed that 4 drugs was inferior to 3 drugs. You might have thought that it was better. In fact, it was inferior, and the reason it was inferior was because of toxicity. SMART was, I think, a triumph that we participated in through the Insight group. Our contribution was led by Sean Emery as in charge of one of the regional coordinating centres, and we recruited mightily to this study. The study compared people who were continuously virally suppressed to people who had intermittent interruptions of therapy based on CD4 count or CD4 driven, on the basis that the toxicity of the drugs might be relieved by intermittent therapy. The result was astonishing. Not only was continuous viral suppression better in terms of progression of disease, of AIDS or death, but people who interrupted therapy had an increased rate of what we have now realised as non-AIDS defining conditions, of increased rates of cardiovascular disease, renal disease, hepatic disease and cancer, which was statistically significant. This was a huge shock and really changed the paradigm of antiretroviral therapy. Looking into the stored samples from this study, the group was able to show that pro-inflammatory cytokines and pro-coagulant molecules such as IL-6 and D-dimer were very, very strongly correlated with mortality, again suggesting that replicating virus is bad for you and has a pro-inflammatory response and pro-coagulopathic response, and probably it's the coagulopathic response that causes some of those cardiovascular events. We set up with Sean Emery's and Mark Boyd's leadership the second-line study, which compared a new strategy of second-line therapy, particularly directed at low and middle-income countries. Second-line therapy consisted, according to WHO guidelines, of boosted Ritonavir with 2 or 3 new or recycled nucleosides. We compared it to using 2 new drugs, in this case a boosted protease inhibitor with the new class of integrase inhibitors as a public health approach. And we're able to show, firstly, that the WHO standard of care, and the first ever randomised trial of second line, that the WHO standard of care was excellent, with a suppression rate of around 80% in people who'd failed first line, and that a new approach, a public health approach of using 2 new classes, was equivalent. Under Sean Emery's leadership, we've been very interested in treatment optimisation and reduced doses of antiretroviral drugs, as the Minister mentioned this morning. The various agencies plan to expand treatment to 15 million people by next year, and this will come at a significant cost. Although reduced in cost over time, the cost of antiretroviral therapy remains quite substantial. Dose reduction may be a means to reduce drug costs. Efavirenz is a very globally important drug, is recommended as the first-line therapy by WHO for all people starting treatment. together with 2 nucleosides, and this was in the new WHO guidelines. A phase 2 trial of efavirenz and various observational cohort data suggested that there was comparable performance of lower daily doses of efavirenz. So we set up the ENCORE study, ENCORE 1 study, comparing 600 milligrams with 400 milligrams. I really sometimes now wish we were a bit bolder and even compared 200 milligrams, which will probably work. But we did what was the conservative approach at the time, and in fact showed that there was absolutely no difference between 600 and 400 milligrams of efavirenz, the major drug used in the rollout, and could potentially save a huge amount of money. Early treatment has become a really vexed question. Together with the Insight group, we are looking at early treatment in a study called START, which is randomised to early treatment with people above CD4 counts above 500, sort of a back to the welcome AZT monotherapy study of enrolling people with high CD4s. Versus a deferred group to less than 350 with 5 years of follow-up. The study is fully enrolled. There are a number of sub-studies in which there is Australian leadership, particularly the bone and the nervous system studies and sub-studies, and we hope to have the first results of where the early treatment is of benefit to the person individually by 2016. What's the treatment cascade like in Australia? Well, these are the latest figures which David Wilson will release this afternoon. There are about 26,000 people on treatment, of whom about 60% are suppressed. In David's group, James Jansen has come up with some modelling which suggests that if we could increase testing by 30% and increase the amount of antiretroviral therapy by up to 80%, we might be able to reduce new infections by 50%. And I think this is the kind of thing that the Minister was talking about this morning, that if we do have a big effort to get more people tested and more people onto treatment, we do have a chance of turning the epidemic in Australia around. So what's the future? START, I think, is a globally important study for determining the clinical benefits of when to start. When to start has been talked about for 30 years of antiretroviral therapy, and finally we'll get an answer. The transmission of benefit of antiretroviral therapy will continue to add tension in the debate between the personal versus the public health benefits of ART. It's an interesting debate to have, and has to be handled sensitively on both sides. Implementation research to show that antiretroviral treatment reduces incidence is going to play a really critical role to resolve this debate. So in other words, if we show that more and more countries, by more widespread implementation of antiretroviral therapy, reduce incidence, then that is really important. Some work on novel approaches. We became very interested in IL-2 in the days of nucleoside monotherapy. IL-2 was able to increase CD4 counts and maintain that increase over time. We set up a large randomised study with Cliff Lane, the NIH, Jim Neaton, and under Sean Emery's leadership in the therapeutic research group here at the Kirby to look at IL-2 in people with HIV. As you can see in that slide, it had a very nice CD4 response. Problem was there was absolutely no clinical benefit, and I think we're still struggling to see where immunotherapy fits in with HIV disease. I think one of the newer technologies will be gene therapy. This is a gene therapy developed from Australian technology by Johnson & Johnson through Jeff Simons when he was working for J&J here in Australia. And this was an anti-ribozyme therapy that was inserted into CD4 cells or macrophages. This provides a sort of an intracellular immunisation, progressively populating the immune system with cells protected against HIV with this anti-HIV ribosome. We did a phase 2A study here in Australia and in California, in Sydney and in California, with this first construct, OZ1, where we mobilised stem cells with GCSF, transfected them took the CD34 stem cells, transfected them with the ribosome and reinfused them back into the patient. And this phase 2 study did not unfortunately reach its primary endpoint. It got close. Secondary endpoints did give some indication of benefit on viral load and viral load rebound. Unfortunately, the marking was only about 0.3%, and it emphasises that if we're going to do gene therapy, then we really need to get constructs that mark a greater percentage of cells, and we may get a better signal for this really fascinating procedure. In the laboratory at the Kirby, under Tony Kelleher's leadership, Kaz Suzuki has been working for a long time on inhibitory RNA, which you can see in vitro. This particular construct of inhibitory RNA directed at the NF-kappa B gene controller for HIV has a dramatic effect in long-term blocking of HIV production in cells which normally support the growth of this. We're now looking at ways in which we could put this or translate this into clinical practice, firstly looking at various animal models and perhaps stem cell transfection with analytic treatment interruptions. So you take a virally suppressed person on ART, administer the inhibitory RNA through CD44 stem cells, allow engraftment, stop antiretroviral therapy, and hopefully the virus would stay latent. And this is the sort of pattern of gene therapy that various groups are looking at right now. So what's the future? I think the success of gene therapy and bone marrow transplantation will depend on whether new approaches to packaging specific anti-HIV gene constructs and creating space in the bone marrow for transfected CD34 stem cells turn out to be safe. I think cure research will continue to be actively pursued. I didn't have time to show you some of our adventures into therapeutic vaccination with constructs developed in Australia. They've really been successful, but I think still could be explored, perhaps not by our group. The last area is in the area of toxicity. With Andrew Carr and the group at St Vincent's, we were able to describe very early on one of the more serious metabolic toxicities of antiretroviral therapy, a syndrome of peripheral lipodystrophy, hyperlipidemia and insulin resistance. We initially thought it was due to protease inhibitors. That was part of the story, and subsequent work by us and other groups, including the Perth group, suggested that nucleosides, particularly thymidine analogues, had a huge contribution to this. These are some patients from Professor Prapan Panapak's clinic in Chula at HivNat, showing some of the features of lipodystrophy syndrome and showing that it's not just restricted to Caucasian people. With Paddy Mallon, when he was doing his PhD with us, was able to show the time course of the development of lipodystrophy when given triple combination, people given triple combination therapy containing thymidine analogues. showing the increase initially in fat as people restored their health, but then over a 3-year period, the very progressive and dramatic reduction in limb fat, which consistently occurred. We did a number of studies to try and see what we could do about this dreadful syndrome of lipodystrophy. This was the MITOC study, which was led by Andrew Carr and Sean Emery, and showed that switching people from thymidine analogues to a less toxic nucleoside, abacavir, was associated with gain in limb fat. And there have been numerous studies since that study which have shown that is a good strategy for dealing with it, although fat is not returned to normal. Paddy Mallon in the lab was able to show how toxic these thymidine analogues are. He biopsied, he took people and gave them, HIV negative people, and gave them thymidine analogues for 2 weeks, and did fat biopsies on them, and was able to show massive changes in gene expression just in 2 weeks of treatment with these drugs, genes that regulate adipose tissue size and genes that regulate mitochondrial metabolism in adipose tissue. Lastly, we've participated in studies of treatment outcomes in antiretroviral therapy, particularly the DAD study on the risk of myocardial infarction in people on long-term antiretroviral therapy. Through AHOD, Matthew Law and his team has participated in this massive study globally and has shown that the recent use and cumulative use of some antiretroviral drugs, particularly abacavir and some protease inhibitors, are associated with an increased risk of myocardial infarction. The issue then becomes what is the impact of HIV versus treatment on inflammation, coagulation and health, and what is the predominant driver. I think it probably is HIV, but we still need to be sure that the safest treatments are given that don't cause these problems. So what's the future? I think these serious non-AIDS conditions, including cardiovascular disease, malignancies, liver and kidney disorders, diabetes, are increasingly problematic for our patients on long-term antiretroviral therapy. The relationship of these events in people who are suppressed to drug toxicity or bad effects of residual virus which might be still replicating in the presence of an ageing person need to be extensively investigated. So lastly, guidelines and policy. I think when one does research, one wants to translate that research into guidelines and policy. I got involved in this very early on. This was the WHO staging system of 1988, which I had the privilege of chairing. This is a 4-stage system that is still widely used today in low and middle income countries to stage people with HIV and to determine treatment eligibility. So this has really stood the test of time. And I continue to participate in various WHO guidelines committees over the years, and I think the one that WHO should be most proud of is the 2013 one released at the meeting in Kuala Lumpur last year of the Consolidated Guidelines for Antiretroviral Therapy. So this is the first time that all the guidelines have been put together for adults, for mothers and children, and also looked at recommendations for operational and service delivery and also programmatic guidelines. And I think WHO should be congratulated for doing an amazing job in getting these guidelines out there. And I think this year in Melbourne, I think their consolidated prevention guidelines are going to be released. Some things have not been so good. This was the PrEP trial in Cambodia. I think it was one of the first PrEP studies. We did everything to the book, but we fell foul of the Cambodian Prime Minister. And I think it taught the field a lot about ways to make sure prevention research with antiretroviral therapy is done in low and middle income countries, and I'm pleased to say that that has now been successfully achieved in many low and middle income countries. The Sydney Declaration, which we had at the IAS meeting in 2007, was a call to scale up research funding with 10% of all resources for HIV programs to go towards research. Unfortunately, that hasn't happened, and it was a sort of a goal. But I think it has made the field aware that much more should be put into the research agenda, particularly with the rollout to get the best results, particularly when we're flatlining the donations to get people on antiretroviral therapy. Lastly, the Melbourne Declaration, again a call for universal access, I think is incredibly important. We need to make sure that vulnerable populations that we work with have universal access to treatment, prevention and care, and hopefully this will promulgate that stand as an outcome from Melbourne. Some acknowledgements. I'd like to acknowledge really deeply all the program heads and staff of the Kirby. I haven't mentioned everyone in this talk because of course not everyone has been worked on antiretroviral therapy. We worked on so many other things, but nevertheless your support and leadership and that of all the staff is extraordinary. We couldn't have done this without the St Vincent's Hospital HIV unit and all the patient volunteers that have gone through our trials both in Sydney, nationally and internationally. Various international HIV research organisations, the NIH, Division of AIDS, MRC, ANRS and so on have been marvellous collaborators. The high caseload primary care GPs in Sydney have been great partners with us, particularly in the area of primary HIV infection. The pharmaceutical industry have been great supporters of our work. And of course, I mentioned the patients, particularly those who volunteered for clinical trials. I want to make some special acknowledgements to people that without whom this work would simply not have been possible. It's and these are amazing people that I've had the privilege of working with over this long period of time. The late Brett Tyndall, Sean Emery, Tony Kelleher, Matthew Law, Andrew Carr, John Caldor, who's been an inspiration in all the work in the Kirby, Cliff Lane at the NIH, Jupp Langer, whose initial insights into antiretroviral therapy were extremely helpful in working out where we should go here, and Professor Prapan Panapak, my friend and colleague from Thailand, who really catalysed our interest in treatment in low and middle income countries. Thank you very much.